Move on to the next speaker. Again, it's with immense joy and pride that I invite my good friend and colleague, Dr. Anup, the face of young Turks of anesthesiology in JSS department. So his achievements include, he's been in the organizing committee member of SZISACON2023 Bangalore. He's the executive committee member of ISA Mysore City branch for the past 6 years. His presentation in the Young Anesthesiologist session in the ISA Karnataka State Conference 2021, lot of laurels. He's got multiple felicitations during Doctor's Day felicitation and from the Rotary Panchil also. He has got a total of 9 publications to his credit. Whole of the JSS department is waiting pre-lunch session, so that speaks immense about the popularity of this young Turk. Over to you, Dr. Anup. Thank you.
Thank you, sir. Thank you for those kind words. At the outset, I would like to thank the scientific committee of the South Zone Conference for giving me this opportunity. I bring greetings from my parent institute, that is the JSS Hospital and Medical College, and I feel extremely privileged to be standing here in front of all my teachers. Thank you so much for what all you have done. My topic for today is somewhat a new topic, post-COVID sequelae, which and what the anesthetist should be concerned about. I would like to start this presentation saying a famous quote from Isaac Newton. What we know is a drop, what we don't know is an ocean. I have a disclaimer. Research on long-term effects of COVID have only just begun. We have just come over the pandemic, so all the problems we're going to see now and points discussed here are based on the studies that are currently available. So why is this topic important? If you see the statistics, the magnitude of the problem, we have on to the left is the world statistics and to the right is the Indian statistics. So many people have suffered COVID and they have recovered. If you look at the Indian statistics, almost 44 million people have recovered from COVID and we don't know what all problems they have developed. So this topic becomes quite important, and this number I feel is small because we all know that so many people did not get tested, they were at their homes, and future slides will tell you even mild forms of infections can land up with post-COVID problems. What makes this topic important? Okay, the media. Any death, any young adult dying of a cardiac arrest, we have a pandemonium in the media telling, is it because of COVID? Is it because of COVID vaccine? So this is headlines from the Times, Economic Times. Alarming rise in sudden heart attacks among Indians post-COVID. Doctors are worried. Then Times of India comes up with COVID link in cardiac death among youths. Okay, this is with the media and obviously with some statistics. But then Nature Medicine came up with a publication on long-term cardiovascular outcomes of COVID-19, where there are so many problems that are associated, which I'll discuss later. But the point here is these risks and burdens were evident even among individuals who were not hospitalized during the acute phase of infection. This is a very valid point to note, that just because we had a milder form of disease, that does not mean we should not develop post-COVID sequelae. Then CDC in their morbidity and mortality weekly report told approximately 1 in 5 adults ages 18 plus have a health condition that might be related to their previous COVID-19 illness. That is a quite significant statistic. And the systems involved is each and every system in the body probably. If you look at the prevalence of the post-COVID sequelae, it is a wide range of 5 to 30%. Why is this wide range? Probably this is because of the differing symptoms or conditions investigated. Not all people come with a cardiovascular problem. Few of them will have psychiatric problems, mental illness, respiratory problems. So the symptomatology is different. Then temporal criteria used is again different. Initially it was 3 weeks. Now the process is going on. We don't know when it is going to end. And the study settings included whether it is outpatient or inpatient, and how symptoms and conditions are assessed also affect the prevalence of post-COVID sequelae. So what are the possible causes? It may be attributable to various pathophysiological processes. initially an organ damage resulting from the acute phase infection. During the acute phase itself, organ is involved and that gets damaged. That leads to the sequelae. Complications of dysregulated inflammatory state. We know the virus did not cause any problem to us. It is our own immunity that damaged most of the organs. So this dysregulated inflammatory state can continue and cause problems in other organ systems. Ongoing viral activity associated with an intra-host viral reservoir, probably because of lack of immunity, some amount of virus can still be there in the body and cause all these problems. Autoimmunity is a major problem. If you talk to endocrinologists or dermatologists for that matter, they will tell you how autoimmune diseases have increased post-COVID. That is again probably because of the dysregulated immune system that COVID did to us. And inadequate antibody response can be one of the other causes. So as anesthesiologists, what we need to know when we have a patient who has recovered from COVID. As I told you, the statistics are so huge. So there is high probability that we'll get frequently patients who have been affected with COVID for anesthesia and surgery. Looking at the respiratory system, they will definitely have some amount of pulmonary fibrosis, new onset respiratory lung disease, small airway dysfunction, impaired diffusion, gas exchange. So many people might have experienced post-COVID, even some amount of exertion, they developed dyspnea. So that is probably because of that impaired diffusion. Impaired respiratory muscle strength and inability to clear pulmonary secretions post-operatively. Just now, my previous speaker mentioned about it, how post-operative pulmonary complications are more common in patients who have recovered from COVID. So what should we do based on the symptom severity? We have to estimate the effort tolerance, be it the 6-minute walk test or any other thing to assess the effort tolerance of the patient. Pulmonary function test needs to be done, which usually shows a restrictive pattern. Lung imaging will definitely tell us which part of the lung and what percentage of lung is involved. And always explain the possibility of post-operative mechanical ventilation in patients who are undergoing intermediate to major surgeries with a history of a severe COVID illness. This beautiful picture I got on a journal, and it is called the COVID heart. You can see how the virus has changed the heart. What is this? Because it is mainly because of the myocarditis that the virus did to the heart, which healed by fibrosis. This myocardial fibrosis leads to increased risk of dysarrhythmias. So many symptomatic and asymptomatic dysarrhythmias we have seen. It increases the risk of ischemic heart diseases, left ventricular systolic and diastolic dysfunction, heart failure, pulmonary arterial hypertension. So what we need to do for this? Consider history of COVID as an independent risk factor for cardiovascular disease, like how we consider smoking as an independent risk factor for cardiovascular disease. History of COVID now becomes an independent risk factor for cardiovascular disease. Keep a low threshold for cardiac investigations, be it echocardiogram or ECG for that matter. Then always try to maintain a positive myocardial oxygen supply and demand ratio in the perioperative period, because the chances of myocardial ischemia, as we all know, because of COVID is quite high. So always to be safe, we try to maintain a positive myocardial oxygen supply and demand ratio. Looking at the kidneys, moderate or severe COVID infection is frequently associated with acute kidney injury. How this kidney gets damaged is because of pre-renal impact of systemic inflammation or direct viral injury through ACE2 receptor. But the point here to note is renal injury may persist beyond acute phases of COVID-19. So whenever we get such patients on table, it is always prudent to use renoprotective strategies and take the best care so that we don't damage the kidneys further. And endocrine system, as we all know, diabetes has increased so many folds after the COVID. What is the reason? Mainly because the virus itself damaging the beta cells, or probably again autoimmunity can be a problem. And Thyroiditis is one more thing. People have developed primary hypothyroidism. And even hypocortisolism is because of the suppression of hypothalamo-pituitary adrenal axis, probably because of steroids. And secondary hypothyroidism is again because of the effect on the pituitary. So once we have such patients, it is always better to look into the amount of glycemic control the patient has or the thyroid profiles before taking them up for surgery. Other system considerations: all post-COVID-19 patients are considered high risk developing DVT. So extreme care should be taken for the prophylaxis of DVT in such patients when they come in for surgery. Physical deconditioning, critical illness myopathy, residual neuromuscular weakness, and increased frailty are problems usually seen post-COVID. So whenever we're using, definitely we'll be using muscle relaxants. So it is absolutely necessary to monitor our neuromuscular blockers before reversing and extubating the patient. Psychiatric problems are very common, ranging from depression, anxiety to post-traumatic disorders post-COVID. So these patients will be on various antipsychotic medications, which will definitely have interactions with our anesthetic drugs. So we need to take into account all these things before planning our anesthetic management. So key takeaways from this lecture: there is a lot to know. Better to be cautious till further research. As of now, history of COVID is a risk factor for cardiovascular diseases. Further evaluation of patients before surgery should be individualized based on patient's physical status and surgical risk. Just because I've told so many problems, that doesn't mean you have to go back and investigate all these systems once you take up a patient. It has to be individualized based on the physical status and the surgical risk. Always try to consider regional anesthesia whenever feasible. Again, coming back to my first slide, it is what we know is still a drop, and what we don't know is still an ocean. Thank you for your time.
Thank you, Dr. Anup, for